Hello everyone, it's Dr. Locklear here, and today we're going to be talking about the concept of acid-base balance, and this is on page 3. This is module 1 in your Pearson text. Acid-base balance can be a little confusing, so there are some good tables in this chapter to help you understand how to interpret an ABG, which is an arterial blood gas. So you can see where the patient is, whether they're in acidosis or alkalosis, and whether it's respiratory or metabolic. This concept is going to cover a broad explanation of acid-base balance, and then the chapters after that break it down into the 4 different categories of respiratory, acidosis or alkalosis, and then metabolic acidosis or alkalosis. So we will hit those one-on-one. So this chapter is going to give you a broad overview. Going through this chapter, it's only about 5 pages, and so the material in this chapter is pretty condensed already, and so most of it is important. So you really need to read this chapter and look at the tables. On page 6, it gives you the common causes of acid-base imbalance. And then on page 8, it gives you the alterations in therapies. And what it does, it takes metabolic acidosis and metabolic alkalosis and respiratory, and it gives you the description of what it is, and then it gives you the clinical manifestations you would see as a nurse. So for example, a patient that's in metabolic acidosis, this is where you have a deficiency of bicarbonate, and you would see nausea, vomiting, weakness. Please read over that. On page 9, there are concepts related to acid-base balance, so the concept of cognition, because when our O2 oxygen levels are affected, we will see changes in mental status. Fluid and electrolytes, and we have covered that previously. Oxygenation, again, if we are not perfusing, it can cause our organs to shut down and cause mental confusion and can lead to death. The concept of perfusion, and stress and coping. So I really like the way this chapter took a chart and related it to the concepts. On page 10, and we're going to go over this pretty thoroughly in class, and I'm going to have some examples of ABGs for you to interpret in class. So page 10 has box 1-1, and it talks about how to interpret ABG. So when they draw the blood for an ABG and you get the results back, you be able to look at it and tell from the results whether the patient's respiratory or metabolic, and whether it's acidosis or alkalosis. And I'm going to go over this little chart here thoroughly. And then on page 12, you have patient teaching about bicarbonate, sodium bicarbonate, and we're going to talk about that as well in this chapter. So I wanted to start out because this is probably, even though it's a short chapter, is probably one of the more harder ones to understand, but the author did a great job in writing this chapter in such a way that you should be able to understand this pretty clearly. So let's get started. So we are going to look at the pathophysiology of acid-base balance, what is happening, what is the mechanisms going on when a person is having an acid-base imbalance issue. We're going to differentiate the alterations in acid-base. You have respiratory acidosis and respiratory alkalosis, or you can have metabolic acidosis or alkalosis. We're going to look at the relationship between acid-base balance and other concepts. And again, that there's a chart on page 9 that shows you the relation to the concepts of cognition, fluid and electrolytes, oxygenation, perfusion, and stress and coping. Explain the promotion of healthy acid-base balance. We're going to look at common assessment procedures and tests used to determine acid-base balance. And a couple of the things that your chapter brings out is interpreting a ABG, which is an arterial blood gas, and they draw the blood from the radial artery to get that blood sample. And then it talks about an Allen test, and we will talk about that. We're going to look at independent interventions by nurses so we can implement care for our patients who have acid-base balance. And we're going to talk about collaborative therapies used by the interprofessional team, because it's not just nurses, the physicians, the respiratory, the pharmacy, because there's medications, and it is a team approach. So let's get started. The concept of acid-base balance. Acid-base balance is critical to homeostasis. We have to have that balance in our body. Our pH levels have to be between 7.35 and 7.45. If we alter from those, then we are going to be in an altered state of homeostasis. And so if the pH drops below 7.35, then we are considered in a state of acidosis. If it is greater than 7.45, then we are considered our bodies in a state of alkalosis. So we have to have that balance. So acid base is critical to optimal cellular function, because as we get into crisis with acidosis or alkalosis, it can shut cell function down, the cells die, and then we can die from that as well. To maintain acid-base balance, the hydrogen ion concentration of body fluids must be kept within a relatively narrow range. So it's a narrow range for that hydrogen ion balance. Hydrogen ions determine the relative acidity of body fluids. So again, the hydrogen ions, if they're out of balance, we see here that it helps balance the acid base in our fluids. Acids release hydrogen ions in solutions. Bases or alkalis accept the hydrogen ions in the solution. The hydrogen ion concentration of a solution is measured as its pH. The relationship between the hydrogen ion concentration and pH is inverse. As hydrogen ion concentration increases, and that's what it means by inverse, as the hydrogen ion concentration increases, the pH falls, and the solution becomes more acidic. Anything below 7.35. As hydrogen ion concentration falls, the pH rises, and the solution becomes more alkaline or base. So let's say that again. As hydrogen ion concentration increases, so the hydrogen ion concentration in the fluids is increasing, the pH will drop, and I'll become in a state of acidosis or acidotic, 7.35 below that. As hydrogen ion concentration falls or starts to decrease, the pH rises and the solution becomes more alkaline or base. The normal pH of body fluids is slightly basic, ranging from 7.35 to 7.45. A pH of 7 is neutral. Normal pH indicates acid-base balance. Acid-base imbalance results from any one of several underlying causes and can be an important clue in diagnosing illness or disease. Failure to restore acid-base balance can lead to impairment of organs and critical bodily functions. So in other words, this is a dangerous situation. We have to be within that pH range, or our body is going to feel adverse effects from it and could lead to death. This is a critical situation. It has to be addressed immediately. The body's tolerance for alterations in acid-base levels is very narrow. A pH below 7 or above 7.6 for even a short time can result in death. And so, again, the normal range being 7.35 to 7.45. So you see here, if it's below 7 or above 7.6, it can result in death. And so, up in the upper paragraph, it says a pH of 7 is neutral. So anything below 7 is critical, okay? Okay. So, our normal acid-base balance. Metabolic processes in the body continuously produce acids which fall into two categories: volatile acids and non-volatile acids. A volatile acid can be eliminated from the body as a gas. Carbonic acid, H2CO3, is the only volatile acid produced in the body, carbonic acid. It dissociates or separates into carbon dioxide, or CO2, and water, H2O. The lungs eliminate the carbon dioxide. So we know when we breathe, our body breathes in oxygen and we exhale CO2. If we obtain too much CO2, we could possibly die from that. Our body cannot tolerate too much CO2. It is toxic to the system. All other acids produced in the body are non-volatile acids that must be metabolized or excreted in fluid. So here's some examples. Examples are lactic acid, resulting from cellular destruction, hydrochloric acid found in stomach secretions, phosphoric acid from the oxidation of phospholipids and phosphoproteins, sulfuric acid formed by oxidation of sulfur-containing amino acids. Most acids and bases in the body are weak, that is, they neither release nor accept a significant number of hydrogen ions. Despite the body's continuous acid production, three systems work together to maintain pH within a normal range. These systems are the buffer systems, the respiratory system, and the renal system. So what is the buffer system? Buffers are substances that prevent major changes in pH by releasing hydrogen ions. When excess acid is present in body fluid, buffers bind with hydrogen ions to minimize the change in the pH. So when the hydrogen ions get a little out of balance, it buffers, it balances it, it removes it. If body fluids become too basic or too alkaline, buffers then release hydrogen ions that restore the pH. Although buffers act within a fraction of a second, their capacity to maintain pH is limited. The body's major buffer systems are the bicarbonate carbonic acid buffer system, the phosphate buffer system, and protein buffers. The normal serum bicarbonate level is 24 to 28 milliequivalents per liter, and the normal serum carbonic acid level is 1.2 milliequivalents per liter. The ratio of bicarbonate to carbonic acid is 20 to 1. Although the amounts of bicarbonate and carbonic acid in the body vary somewhat, as long as this ratio is maintained, the pH remains within 7.35 to 7.45, and again, that's where we want to be. Bicarbonate is a weak base. When an acid is added to the system, the hydrogen ion in the acid combines with bicarbonate, and the pH changes only slightly. Carbonic acid is a weak acid produced when carbon dioxide dissolves in water. When a base is added to the system, it combines with carbonic acid and the pH remains within the normal range. So we know this bicarbonate, again, it's a weak base, and when an acid is added to the system, the hydrogen ion in the acid combines with the bicarbonate and the pH only changes slightly. Carbonic acid is a weak acid produced when carbon dioxide dissolves in water. So again, it's going to help maintain the pH of the system by buffering it and attaching to these hydrogen ions. Adding a strong acid to extracellular fluid depletes bicarbonate, changing the 20:1 ratio and causing the pH to drop below 7.35. This is known as acidosis. Adding a strong base depletes carbonic acid as it combines with the base, again disrupting the 20:1 ratio. The pH rises above 7.45, a condition known as alkalosis. So again, here we see that all of this is based on the balance of these hydrogen ions and carbon dioxide and how much buffer is added to balance. If too much buffer is added or not enough, then we are going to be in acidosis or alkalosis. And again, there are your three major buffer systems, your bicarbonate, your phosphate, and your proteins. All right, the respiratory system, what does it do? The respiratory system and the brain's respiratory center regulates carbonic acid by eliminating or retaining carbon dioxide. Carbon dioxide is a potential acid. When combined with water, it forms carbonic acid, a volatile acid. Acute increases in carbon dioxide or hydrogen ions in the blood stimulate the brain's respiratory center, increasing both the rate and depth of respiration. So if we have too much CO2, then the brain's going to kick in and say, hey, I got too much. You need to breathe better. You need to get it out. As a result, carbon dioxide is eliminated and carbonic acid levels fall, bringing the pH to a more normal range. Although this compensation for increased hydrogen ion concentration occurs within minutes, it becomes less effective over time. For example, patients with chronic lung disease, such as COPD, may have consistently high CO2 or carbon dioxide levels in their blood because with COPD, such as emphysema, that's a COPD disorder, they can breathe in oxygen, they just don't have the ability to expel the CO2. So they're always in the pretty much imbalance with their pH. Alkalosis, by contrast, depresses the respiratory center, decreasing both the rate and depth of respiration and causing carbon dioxide retention. The retained carbon dioxide then combines with water to restore carbonic acid levels and bring the pH back within normal range. So when you read it, it makes sense. It's a check and balance system. Okay, so if this level gets high, then if your hydrogen ions are not doing what they're supposed to do, your CO2 is too high or too low, these systems are going to kick in and say we're out of balance, we need to do something. Okay, and again, the respiratory system focuses on the carbon dioxide, and so it will say, you've got too much or too little. All right. Then the renal system, what does it do? The renal system is responsible for the long-term regulation of acid-base balance. The kidneys normally eliminate the excess non-volatile acids produced during metabolism. So during metabolism, when components are broken down into energy, then these toxins that our body doesn't need are released filtered through the kidneys and out through the kidneys. The kidneys also regulate bicarbonate levels in extracellular fluid by regenerating or reabsorbing bicarbonate ions in the renal tubules. Although the kidneys respond more slowly to changes in pH over hours to days, they can generate bicarbonate and selectively excrete or retain hydrogen ions as needed. In acidosis, when excess hydrogen ions are present and the pH falls, the kidneys excrete hydrogen ions and retain bicarbonate. In alkalosis, the kidneys retain hydrogen ions and excrete bicarbonate to restore acid-base balance. So through the process of filtration, the kidneys are going to help us maintain balance by working with these hydrogen ions to balance those out. So alterations to acid-base balance. Acid-base imbalances fall in two major categories, acidosis and alkalosis. Acidosis occurs when the hydrogen ion concentration increases above normal pH below 7.35. Acidosis below 7.35. Alkalosis occurs when the hydrogen ion concentration falls below normal and the pH is above 7.45. So again, acidosis occurs when the hydrogen ion concentration increases, so the pH will drop. Alkalosis occurs when the hydrogen ion concentration decreases or falls below normal, and then the pH will be above 7.45. Alterations and manifestations. Acid-base imbalances are further classified as metabolic or respiratory. In metabolic, the primary change is in the concentration of the bicarbonate. In metabolic acidosis, the amount of bicarbonate decreases in relation to the amount of acid in the body. This condition can develop from abnormal bicarbonate losses or from excess non-volatile acids in the body. So you have a buildup of these acids. The pH falls below 7.35 and the bicarbonate concentration is less than 24 milliequivalents per liter. So if you have a pH below 7.35 and a bicarbonate below 24, then you're going to have metabolic alkalosis. By contrast, I'm sorry, I said that wrong. Let me re-say that. That's not right. The pH falls below 7.35 and the bicarbonate concentration is less than 24. So this is metabolic acidosis. Let me make a correct, my words are running together here in the reading. So let's just go over that again. In metabolic acidosis, the amount of bicarbonate decreases in relation to the amount of acid in the body. This condition can develop from abnormal bicarbonate losses or from excess non-volatile acids. The pH drops below 7.35 and the bicarbonate is less than 24. This is metabolic acidosis. Now, metabolic alkalosis, by contrast, there's an excess of bicarbonate in relation to the amount of hydrogen ion. The pH is above 7.45 and the bicarbonate concentration is greater than 28. And we will talk about this in class as well. I'll make sure and get you straight. In respiratory disorders, the primary change is in the concentration of the carbonic acid. Respiratory acidosis occurs when carbon dioxide is retained, increasing the amount of carbonic acid in the body. As a result, the pH falls to less than 7.35 and the PaCO2, which is pressure exerted by dissolved carbon dioxide in the blood, is greater than 45. When too much carbon dioxide is lost, carbonic acid levels fall, and respiratory alkalosis develops. The pH rises to 7.45 and the PaCO2 is less than 35. So you see here, when you got respiratory acidosis, you have a pH of 7.35, less than 7.35, and the PaCO2 is greater than 45. When you have respiratory alkalosis, the pH rises to 7.45 and the CO2 is less than 35. And I know that's confusing, but the more you read it, the more it will make sense. Any condition that causes hypoventilation may result in respiratory acidosis and hypoxemia, while any condition that causes hyperventilation often results in respiratory alkalosis. So hypoventilation, you're not breathing enough. Hyperventilation, you are breathing too rapidly. Acid-base disorders are further defined as primary, which are simple, and mixed. Primary disorders usually have one cause. For example, respiratory failure often causes respiratory acidosis due to retained carbon dioxide or CO2. Renal failure usually causes metabolic acidosis due to retained hydrogen ion and impaired bicarbonate production. And we're going to look at table 1-1. Mixed disorders occur from combinations of respiratory and metabolic disturbances. So you can have a patient that's having respiratory issues and kidney issues at the same time. For example, a patient in cardiac arrest develops a mixed respiratory and metabolic acidosis due to lack of ventilation, retained CO2, and hypoxia of body tissues that leads to anaerobic metabolism and acid byproducts, excess non-volatile acids. So you can have both. The patient can be in a state of kidney problems along with respiratory problems. Look on page 6, table 1-1. So you have metabolic acidosis. So the pH is less than 7.35 and the bicarbonate, that's that HCO3, is less than 24. Metabolic alkalosis, your pH is greater than 7.45 and your HCO3 or bicarb is greater than 28. And you see some common causes listed on the side here that would lead to some of these conditions. Respiratory acidosis, your pH is less than 7.35 and your PaCO2 is greater than 45. In respiratory alkalosis, your pH is greater than 7.45 and your PaCO2 is less than 35. So please study this chart, and we're going to do some practice ones in class. So what happens when we have a term called compensation? This is where your body is trying to correct the acid-base imbalance, okay? With primary acid-base disorders, compensatory changes in other parts of the regulatory system occur to restore a normal pH and homeostasis. It's trying to compensate, it's trying to repair the condition. In metabolic acid-base disorders, the change in pH affects the rate and depth of respirations, which in turn affects carbon dioxide elimination and the PaCO2, and helps restore the ratio of carbonic acid to bicarbonate. The kidneys compensate for simple respiratory imbalances. The change in pH affects both bicarbonate conservation and hydrogen ion elimination. Look at table 1-2 on page 7. With metabolic acidosis, you have an excess of non-volatile acids and a bicarbonate deficiency. So you got too much non-volatile acids, not enough bicarb. The rate and depth of respirations increase, eliminating CO2. So the effect on the ABG is a decreased pH, a decreased HCO3 or your bicarbonate, and a decreased PaCO2. In metabolic acidosis, this is a bicarbonate excess, rate and depth of respirations decrease and CO2 is retained. So the pH will increase, the bicarb will increase, and the CO2 will start to increase. Respiratory acidosis, you have retained CO2 and excess carbonic acid. Kidneys conserve bicarbonate to restore carbonic acid, a bicarbonate ratio of 1 to 20. So now with respiratory, the pH will start to come down. Okay, you'll see the pH will be down, the CO2 will be up, and the bicarb will be up. Okay, and then in respiratory alkalosis, you have a loss of CO2 and deficient carbonic acid. Kidneys excrete bicarbonate and conserve hydrogen ions to restore carbonic acid and bicarbonate ratio. So with respiratory alkalosis, you'll see an increased pH, decreased PaCO2, and a decreased bicarb. And I know this is confusing, but trust me, the more you read it and as you become a nurse and become exposed to it, it will make sense. So don't stress. I just really need you to read this chapter, okay? That's very important. Read this chapter. We're going to try to cover everything as much as we can. Compensatory changes in respirations occur within minutes of a change in pH. These changes become less effective over time. The renal response takes longer to restore the pH, but it is a more effective long-term mechanism. If the pH is restored to normal limits, the disorder is considered fully compensated once the pH is back in balance. When these changes are reflected in arterial blood gases, your ABG, the values, but the pH remains outside normal limits, the disorder is partially compensated. So when you see changes in the ABG, the pH still remains outside normal limits, but you can tell that it's trying to come up because you'll see the pH, say it was down to 7.20 and now it's back up to 7.25. It's still abnormal, but it's trying to compensate, so you'll see the changes in the pH trying to get back to the normal baseline. Risk factors. Acid-base imbalances occur in critically ill patients. There are many underlying causes of these disturbances. Each acid-base disorder is treated separately with the underlying cause considered in these patients. So each one, if it's metabolic or respiratory, they're caused by specific things and they have to treat what's causing it. So concepts related to acid-base balance, and again, this is on page 9, and we've got the concept of cognition. So as the CO2 decreases, it can cause changes in cognition, leading to impaired communication. We want to adequately oxygenate the patient, monitor for further changes in the level of consciousness. It can lead to stupor and coma. We need to notify the healthcare provider. Ask yes or no questions and observe for nonverbal cues. The concept of fluid and electrolytes. Focus treatment primarily on the disorder. Reduce the effects of acidosis on cardiac function and restore fluid levels. Administer IV bicarbonate as ordered. Administer IV fluids with insulin to correct acidosis in patients with DKA. Rapid administration of sodium bicarbonate leads to metabolic alkalosis and hypokalemia, so we have to be careful not to do it too rapidly. Monitor ABGs. Oxygenation, monitor respirations, monitor the vital signs in the pulse ox. Give special attention when respirations are 12 or less. Determine cause of treatment based on the cause. Severe hypoventilation requires an opioid antagonist such as naloxone or Narcan. Monitor respirations in all patients. Calm patient because the more anxious they are, the faster they're going to breathe. Offer stress reduction counseling if they're having anxiety. Speak in a slow, calm voice. Perfusion. Again, administer oxygen. Correct underlying problem to improve perfusion to the organs. And then stress and coping. Reassure patient, provide distractions, and teach guided imagery. So under the concepts related to acid-base balance, it says, for example, changes in acid-base balance can result in decreased tissue perfusion, leading to cardiac arrest. Acidosis or alkalosis may result in decreasing level of consciousness, and patients with acute respiratory acidosis may also experience irritability and altered mental status. Chronic respiratory acidosis can manifest in impaired memory and/or personality changes. Metabolic acidosis resulting from fluid or electrolyte imbalance can be particularly dangerous, especially in the case of diabetic ketoacidosis or DKA. The concepts related to acid-base balance feature links, but not all of the concepts related to the acid-base balance, and you will see they're presented in this chart on page 9. And we've gone over that pretty thoroughly. Health promotion, it focuses on maintaining fluid balance. Both overhydration and dehydration can result in acid-base imbalances. Chronic conditions that can easily cause a change in fluid status and subsequent acid-base imbalances include diabetes, Crohn's disease, chronic kidney disease or CKD, and chronic lung disease such as COPD. Electrolyte imbalances, particularly sodium and potassium, may be caused by certain medications, supplements, or changes in diets. Nurses focus on patient teaching regarding adequate nutrition, taking medications as prescribed, and following treatment regimen for chronic illnesses. So our nursing assessment. Focused assessment related to acid-base imbalances include the following. You should begin by identifying patients at risk for acid-base disturbances, including those who have a risk for significant electrolyte imbalances, people that are dehydrated or kidney patients, people that have nausea and vomiting from chemo and things of that nature. Net gain or loss of acids, net gain or loss of bases, ventilation abnormalities, problems with breathing, again, kidney function and metabolic malfunction. Consider what the patient's vital signs are telling you. Count the patient's respirations for a full minute. Consider the rate and depth of respirations in your assessment. Do you see any reasons why the patient should have impending or underlying respiratory or metabolic problems? What is the patient's level of consciousness? Decreased LOC can be a sign of an acid-base disturbance. What are the fluid balance and kidney function of the patient? What is their intake? How much are they taking in? What is their output? It's so important to monitor I's and O's. Do your findings correlate with the patient's diagnoses? And look on page 8, and you will see alterations in therapies, and it lists the 4 categories, metabolic or respiratory, and it gives you the description and definition of each, and then the manifestations you will see, and a lot of them sound the same. Observation and patient interview. Acid-base balance is a function of the chemical and physiologic components of the body. A complete health history is necessary to determine the underlying imbalance. Each specific disorder has different symptoms. It is important to identify any prescribed and over-the-counter medications that the patient is currently taking, as well as any complementary health approaches such as vitamins and herbal supplements. Physical exam. assess the patient's vital signs, including their pulse ox, mentation, use fall precautions if they have decreased level of consciousness, look at skin color and temperature, rate of respirations and count for a full minute, lung sounds, bowel sounds, urine output may be among the indicators of a change in acid-base balance. And so again, I's and O's and intake versus output. Are they dehydrated? Is their urine output little to none? All that needs to be monitored and reported. Monitor and report, assess and report. Diagnostic test. So what's an ABG? Acid-base balance is assessed primarily by measuring arterial blood gases, or an ABG. Arterial blood gas is most often used because it reflects acid-base balance throughout the entire body better than venous or capillary blood that has dispersed oxygen into the tissues and has collected carbon dioxide. Venous blood gases are occasionally ordered when frequent ABGs have resulted in damage to the normal arterial gas sampling sites. Arterial blood also provides information about the effectiveness of the lungs in oxygenating blood. When a patient has chronic retention of serum CO2, it is reflected in a metabolic panel. If the history of long-standing chronic lung disease is unknown, it is often helpful to look at serum CO2 as a trend. And we do the ABG in the radial artery, and it's you take the needle and it's a straight stick right in the radial artery, and then it has to be put on ice and taken to the lab to be tested. Other things that we can do are the Allen test. A modified Allen test is a measurement of ulnar patency. The patient elevates the hand and repeatedly makes a fist while the examiner places digital occlusive pressure over the radial and ulnar arteries of the wrist. And as you see in the picture, you use your thumbs to do that. The hand will lose its normal color because you're cutting off the blood supply. Digital pressure is released from one artery while the other remains compressed. The return of color indicates that the hand has good collateral supply of blood and that arterial puncture can safely be performed. So you want to make sure you're testing so you can make sure that they're perfusing well, and that's a good site to get the ABG. Blood gases may be drawn by the respiratory therapist, healthcare providers, or nurses with specialized skills such as works in intensive care. When I worked in intensive care, we were allowed to draw ABGs, and it takes practice. It's not easy. Because blood is drawn from a high-pressure artery, it is important to apply pressure to the puncture site for 10 minutes, more than 10 to 15 minutes if the patient is on anticoagulant therapy, after the procedure to reduce the risk of bleeding and/or bruising. A systematic approach is important in the analysis of ABG results. First, evaluate each individual measurement, then analyze the interrelationship to determine the acid-base balance. So look at box 1-1 on page 10. So the first thing you want to do is look at the pH. You got to determine if it's acidosis or alkalosis. So if it's acidosis, the pH is less than 7.35. If it's alkalosis, it's greater than 7.45. Look at the PaCO2. If the PaCO2 is less than 35, then that's going to be considered too low, okay? Or if it's CO2 greater than 45. So if you've got less than 35, you've got more carbon dioxide is being exhaled than normal. If it's greater than 45, carbon dioxide is being retained. So now you want to evaluate the pH and CO2 relationship. If the pH is 7.35 or below 7.35, acidosis, and the PaCO2 is greater than 45, hypercapnia, Retained carbon dioxide is causing increased hydrogen ions and respiratory acidosis. If the pH is greater than 7.45, alkalosis, and the CO2 is less than 35, hypocapnia, low carbon dioxide levels and decreased hydrogen ion concentrations are causing respiratory alkalosis. Now you want to look at the bicarb. If the HCO3 is less than 24, bicarbonate levels are lower than normal. If they're greater than 28, then they're higher than normal. So now you want to evaluate the pH and the bicarb and base excess. If the pH is less than 7.35, the bicarb is less than 24, and the base excess is less than -3 if you have that reading, then low bicarbonate levels and high hydrogen ion concentrations are causing metabolic acidosis, regardless whether it's metabolic or respiratory. If it's below 7.35, it's acidosis. If it's greater than 7.45, it's alkalosis. And then you have to look at the PaCO2 and the bicarb to determine if it's respiratory or metabolic, or if you have a mixed, if there's both going on. If the pH is greater than 7.45, the bicarb is greater than 20, and the base excess is greater than +3, then high bicarbonate levels are causing metabolic alkalosis. Look for compensation, and this is where it gets tricky, okay? I always have to refer to my notes to determine compensation. Renal compensation. In respiratory acidosis, the kidneys retain bicarb to buffer the excess acid, so the bicarb is greater than 20. So in respiratory acidosis, if you're compensating, the pH will be less than 7.35, the CO2 greater than 45, and the bicarb will be greater than 28. It's trying to compensate. The bicarb is trying to buffer and compensate. Okay, so this when you're looking at compensation, you have to look at the pH, the PaCO2, and the bicarb. In respiratory alkalosis, the pH is greater than 7.45, the CO2 is less than 35, and the kidneys excrete bicarbonate to minimize the alkalosis, so the bicarb is less than 24. So it will be less, the bicarb will change because it's trying to compensate, just as it is in respiratory acidosis. Respiratory compensation. In metabolic acidosis, the pH is less than 7.35, the bicarb is less than 24, the rate and depth of respirations increase, increasing carbon dioxide elimination, so the CO2 is less than 35. So now this is metabolic acidosis. In metabolic alkalosis, so you're going to look at the pH, it'll be greater than 7.45, the bicarb will be greater than 28, so we know that's metabolic acidosis. But the CO2 will be greater than 45 because it's trying to compensate. Okay, so we'll talk more about that when we get to the class. Okay, and again, the diagnostic test, the PaCO2 measures the pressure exerted by the dissolved carbon dioxide in the arterial blood and reflects the respiratory component of acid-base regulation and balance because it is regulated by the lungs. The normal value is 35 to 45. PaCO2 less than 35 is known as hypocapnia. PaCO2 greater than 45 is known as hypercapnia. Healthcare providers often look at venous CO2 when chronic CO2 retention occurs. The PaCO2 can be abbreviated further as PCO2 and the PO2. The P stands for partial pressure, or the pressure exerted by the gas dissolved in the blood. The A indicates that the sample is arterial blood. Because these measurements are rarely done on venous or capillary blood, the A is often deleted from the abbreviation, and that's just good information to know, but you're not going to be tested on that. The PaO2 is a measure of the pressure exerted by oxygen that is dissolved in the plasma. Only about 3% of oxygen in the blood is transported in solution. Most is combined with hemoglobin. However, only dissolved oxygen is available to the cells for metabolism. As dissolved oxygen diffuses out of the plasma into the tissues, more is released from the hemoglobin. The normal value for PaO2 is 75 to 100. So this is your actual measurement of oxygen in the plasma, and it's 75 to 100. The PaO2 less than 80 indicates hypoxemia. The PaO2 is valuable for evaluating respiratory function, but it is not used as a primary measurement in determining acid-base status. The sodium bicarb or serum bicarb reflects the renal regulation of acid-base balance, and again, the normal is 24 to 28. Then you have your base excess. Is calculated value also known as a buffer base capacity. The base excess measures substances that can accept or combine with hydrogen ions. It reflects the degree of acid-base imbalance by indicating the status of the body's total buffering capacity. It represents the amount of acid or base that must be added to a blood sample to achieve a pH of 7.4 and is essentially a measure of increased or decreased bicarbonate. The normal base excess is -3 to +3. It is important to correlate the results of the pulse ox with the ABGs. When pulse oximetry is reading a low percentage, it may not correlate to the accurate number in the arterial sample. For example, when perfusion is low, your pulse ox reading does not correlate to arterial oxygenation. It may be necessary to record the pulse ox reading and perform an ABG at the same time to correlate the difference. The oxygen saturation of 90% corresponds to about a PaO2 of 60. Other reasons for false readings include anemia because of the lack of the hemoglobin molecule, carbon monoxide poisoning, hypothermia, hypotension, peripheral vasoconstriction, and poor peripheral perfusion caused by disease. Remember that arterial blood is the gold standard and most accurate reading for the patient. So again, this text really is, if you just sit down and read it, is very clear. So if you have a CO2 less than 35, you're hypocapnia, and CO2 greater than 35, you're hypercapnia. And so those are just two terms that you need to know. Again, I think there's a mistype on this slide here. Look on page 10. It says the normal value is 35 to 45. PaCO2 less than 35 is known as hypocapnia. PaCO2 greater than 45 is known as hypercapnia, and your slide here says greater than 35. That is incorrect. It is greater than 45, so please make that note. Steps in interpreting an ABG. Again, this is in box 1-1, and we went over that really thoroughly. But again, you want to look at the pH. We're going to go over this in class, and we'll give you some exercises to do. Look at the PaCO2, evaluate the pH and the PaCO2 relationship. Then look at your bicarb and evaluate that and your base excess, and look for compensation. So again, in compensation, if it's respiratory, then the bicarb's going to show compensation. If it's metabolic, the CO2 is going to show, the PaCO2 is going to show compensation. And we'll talk more, I'll answer your questions about that. Independent interventions. The nurse approaches acid-base imbalances by taking vital signs and obtaining a thorough patient history. It includes cardiac, renal, pulmonary, current meds, medical conditions, and other symptoms. For patients in severe distress, family members may need to be consulted for critical information, including the most recent eating habits and history of vomiting. When taking the patient's health history, the nurse should consider conditions potentially related to culture and developmental stages. And so some of the things we want to look at is taking a daily weight, monitoring their I&O, assessing respiratory and renal function. Remember, if it's below 12, we have a problem. Maintaining a patent airway, monitoring oxygen saturation, taking the vital signs. Do we have increased respiratory rate, decreased respiratory rate, tachycardia? Assess level of consciousness and neurological function. Are there changes? And promptly reporting changes to the healthcare provider. Assess and report any abnormal findings. Remember, we are nurses. We analyze data. So don't just go through the process of doing the skills. Why am I taking a weight? Have they gained weight? Have they lost weight? I's and O's, that indicates if they're over hydrated or underhydrated. They're dehydrated. Is the respiratory rate below 12, or are they breathing too fast? Renal function, are they putting up and out enough urine compared to what they're taking in? So analyze your data. Is the pulse ox below 90? What does their skin color look like? Are they confused? Notify the physician. We assess and report. That's what we do. Collaborative therapies. Untreated severe metabolic acidosis can lead to myocardial depression or myocardial infarction, seizures, shock, and multi-organ failure. The goal of treatment is to restore or maintain normal body balance. Treatment of acid-base balance depends on identification and treatment of their underlying cause and reversing it. It also is a collaborative care for acid-base imbalance depends on identification of the underlying cause and correcting that cause. What's causing this person's body to be out of balance? There is ongoing collaboration with the healthcare team, ongoing assessments. Never stop assessing. Assess every time you go in the patient's room, especially a patient that's in critical condition. Pharmacologic therapy. Careful monitoring of ABG levels prevents over-treatment that causes pH to alter in the opposite direction, changing alkalosis to acidosis or acidosis to alkalosis. In patients with acidosis, the therapeutic goal is to reverse the effects of excess acids in the blood and return the patient to normal pH level as quickly as possible. This is a medical emergency. The pharmacologic treatment of choice for acute acidosis is sodium bicarbonate infusions, provided that the patient's bicarbonate level is low. The bicarbonate ion acts quickly as a base to neutralize acids in the blood and other body fluids. Carefully monitor the patient's ABG during infusions and watch for signs of alkalosis. Sodium bicarbonate can overcorrect the acidosis, causing blood pH to turn alkaline. Symptoms of alkalosis include irritability, confusion, cyanosis, slow respirations, irregular pulse, and muscle weakness. Again, the more reason we assess every time we go to that patient. If these symptoms occur, withhold the medication and notify the healthcare provider. The nurse's role in sodium bicarbonate therapy. I've already said that. Carefully monitoring the patient's condition and educating the patient and family about the prescribed treatment. Sodium bicarbonate is given to neutralize the acidotic state. So first analyze the ABG reports of pH, carbon dioxide levels, the bicarbonate levels, and oxygen saturation, the PaO2 and O2 sats. Assess the patient for symptoms associated with acidosis such as sleepiness, coma, disorientation, dizziness, headache, seizures, and hypoventilation. Also assess the patient for causative factors that could produce acidosis, such as diabetes or DKA, shock, diarrhea. Successful management of the underlying disease condition frequently corrects acidosis. So remember, we've got to assess, report, so the physician can make the right call and correct the condition. Sodium bicarbonate is used only in patients with a pH less than 7.2. Several contraindications and precautions are related to the administration of sodium bicarbonate. It should be used judiciously in patients with cardiac disease and renal impairment because of the sodium content. Sodium bicarbonate is also used to alkalinize the urine and speed the excretion of acidic substances. This process is useful in treating overdoses of certain acidic medications such as aspirin and phenobarbital, which is a seizure drug, and is useful in adjunctive therapy for certain chemotherapeutic drugs such as methotrexate. Sodium bicarbonate is also used in chronic renal failure to neutralize the metabolic acidosis that occurs when the kidneys cannot excrete hydrogen ion. IV sodium bicarbonate causes the urine to become more alkaline. Less acid is reabsorbed in the renal tubules, so more acid and acidic medicine is excreted. This process is known as ion trapping. During ion trapping, monitor the patient's acid-base status closely and report symptoms of imbalance. Provide care directly towards supporting critical bodily functions such as cardiovascular, respiratory, and neurologic status, which may be impaired secondary to drug overdose. Sodium bicarbonate baking soda is used as a home remedy to neutralize gastric acid, relieving heartburn and sour stomach. Although occasional use is acceptable, nurses should be aware that patients may misinterpret cardiac symptoms as heartburn and overuse sodium bicarb, which may lead to alkalosis. Patient education as it relates to sodium bicarbonate should include the goals of therapy, the reasons for obtaining the baseline data such as vital signs and electrolyte levels and possible drug side effects. And on page 12, you have patient teaching of sodium bicarbonate. And I want you to know this. Immediately contact the primary healthcare provider if gastric discomfort continues or is accompanied by chest pain, dyspnea, or diaphoresis. Use non-sodium antacids to prevent the absorption of excess sodium of bicarbonate into systemic circulation. Do not use any antacid, including sodium bicarbonate, for longer than 2 weeks without consulting your healthcare provider, because it's sodium bicarb and we don't want too much in the system. And then the last part of this chapter, airway management. Patients experiencing respiratory distress may require intubation. Although there is no specific rule for when to intubate, generally intubation is indicated if the patient has a PaCO2 greater than 77, a PaO2 less than 60, and a pH less than 7.20. Patients with chronic hypercarbia require care to correct their status slowly, as correcting PaCO2 too quickly may result in metabolic alkalosis due to excessive retention of the bicarbonate. Patients with hypoxemia may also require supplemental oxygen, which has been shown to improve outcomes and reduce mortality rates. Mechanical ventilation and oxygen administration are we discussed that in another concept of oxygenation, but we still need to know what's going on and why they need to be put on a ventilator. Bilevel positive airway pressure, or BiPAP, may be an option for certain patients who are not in immediate need of intubation and who meet certain criteria that include severe respiratory distress and acute respiratory acidosis, especially if intubation is contraindicated. Monitor patients receiving BiPAP therapy for pneumothorax and hypotension secondary to decreased venous return. So, again, this chapter is very detailed. It explains it very thoroughly. If you will read this chapter, you will have a good understanding and focus on the reading. Like I said, it's only 5 pages, and it tells you exactly what's going on and how to interpret an ABG, and we're going to talk more about this in class. That's it. Thank you.